صباح الخير. I will talk about the vitreoretinal aspect of dropped lens matter, whether it's a nuclear fragment or whole nucleus or cortical material. Vision loss after complicated cataract surgery with retained crystalline lens fragments plagues unfortunate patients, cataract surgeons, and vitreoretinal surgeons, originally referred to as the lost lens syndrome, described by Maurice Landers. However, the lens isn't lost, the cataract surgeon knows exactly where it is. So I think there are four important questions. I think maybe the first two were well covered by my previous speakers, Dr. Basim, Dr. Tariq Mahmoud, Dr. Ahmed Assaf. I will just go briefly on them, then I will go into the core of my talk, which is vitreous surgery for such cases. The incidence of dropped lens matter, which is difficult really to assess, has been reported to be between 0.4 to 4%, with the lowest reported rates of retained lens fragments. Most surgeons may confront this situation only once every couple of years. However, the incidence of dropped nucleus was more frequent with inexperienced surgeons. So inexperience, I think, is the most important risk factor for a dropped lens matter, even though experienced surgeons had more cases with predisposing risk factors. And this was a study that was published in the Cataract and Refractive Surgery journal. So what happens? The most common surgical steps contributing to posterior capsule dehiscence and subsequent dropped nucleus was previously described, so I will not go into this. This is not my specialty. However, there are certain risk factors that were mentioned. Posterior polar cataract is really a tough and challenging case. Hard cataracts, total cataracts, radial tears in capsulexis, as shown by Professor Tariq Mahmoud. Topical anesthesia. I would just want to stress on vitrectomized eyes. If you don't have enough experience, don't operate on fluid-filled eyes after vitrectomy, because once you go inside these eyes, the pressure goes down, and you may be faced with a hypotenuse eye. So unless you have good experience with those, with cataract surgery, refer it to a more experienced surgeon. So what should be done when it happens? What guidelines can be offered to surgeons based on evidence-based medicine confronted with posteriorly dislocated lens fragments? The cataract surgeon watching a falling nuclear fragment should immediately stop and check a pulse rate, and this is his own first. This is an excellent time, okay, to recall the first principle of medical practice, as Dr. Tariq said. First, do not harm everything. Do not harm the iris, do not harm the cornea, do not meddle with the vitreous if you do not experience with. So it's very important not to induce tissue damage. So what should be done again? Mounting evidence shows that a cataract surgeon's intraoperative management of intravitreal lens fragments plays a critical role in determining the final outcome. So you are the most important factor determining the outcome of this patient, not the vitreous surgeon. The surgeon's immediate goal should be to avoid either overreacting or underreacting to the situation. Specifically, do just as much surgery as indicated, but no more. So, what are the attitudes of cataract surgeons in such a situation? First, some may undermanage the case. So when faced with a capsular rupture, especially if you do not have enough experience, maybe the first time for you, with a lens fragment that is posteriorly dislocated, some surgeons, out of fear, frustration, inexperience, may opt to terminate the case quickly. This almost certainly leaves the vitreous in the anterior chamber incrustated into the wound. At best, this increases the risk of postoperative cystoid macular edema, and in less fortunate eyes, endophthalmitis and retinal detachment. On the other side, overmanagement. Other surgeons at the other end of the spectrum reside many aggressive cataract surgeons with strong drives to fix the problem. They don't want vitreous surgery. They think that vitreous surgery will turn the case into something that is ugly, which is not the case actually. So some include reaching posterior to the fragments through limpet incisions, either by direct visualization or by using, some have invented something like a microscope slide over a cover slip as an improvised contact lens. Alternatively, some authors propose fishing for fragments by infusing saline into the vitreous. Some anterior segment surgeons may have recently championed a technique called posterior assisted levitation for retrieval of retained lens fragments. However, other caution against such actions because they exacerbate vitreous prolapse, create uncontrolled traction on the vitreous base. You don't know exactly the vitreoretinal relation in such case. Some patients have adherent vitreous to the vitreous base. So once you cause traction, you can easily create a giant retinal break, and I have seen it with some surgeons. You send the case to you, you have some dislocated lens matter, and you'll find a detachment with a giant retinal break. And this probably increases the risk of retinal detachment, and ample data from several series have shown that retinal detachment constitutes a major reason for vision loss in these patients. So what should be done when it happens? A more prudent approach is for the cataract surgeon to realize, once he sees a dropped nucleus or lens fragment, that this has now become a two-surgeon problem, if he's not a vitreous surgeon. That requires both his skills and those of a vitreoretinal surgeon. So what should be done when it happens? Most experts advocate that cataract surgeon should go through these 5 steps. First, perform an anterior vitrectomy as shown by Professor Assaf. Remove fragments from the anterior chamber and the capsular bag. Place an IOL in the ciliary sulcus or capsular bag. The surgeon should ensure that the implant is stable. You don't want to refer such a case with a shaky IOL. You don't want a dropped IOL on top of a dropped lens matter. So it does not dislodge when the vitreous surgeon performs scleral depression to remove entrapped fragments and collapsed vitreous. The corneal incision should be sutured to promote wound healing and integrity, because once we go with a vitrectomy, we don't want a collapse of the anterior chamber, and the patient and his family should be promptly informed of the situation if you are going to postpone the case to a second day or a third day. Be frank, be honest. This is the most important thing that protects you against medical legal issues. Again, the type of IOL to be implanted has been discussed, but I want to stress again, putting a single piece IOL in the sulcus. You can see that the edge of these IOLs are quite rough, and they can induce inflammation, uveitis, glaucoma. So if you don't have this, the 3-piece IOL, I think you should postpone implantation. Again, the problems that you are faced with, complications of a sulcus, place single-piece acrylic IOL, pigment dispersion, iris transformation, and maybe sometimes restored macular edema. So sometimes we need to remove this IOL and put a proper IOL. Again, these are just illustrations. I will not discuss this. So a 3-piece IOL has the advantage of being thin, posterior angulated, C-shaped haptics. And again, this was being described by Dr. Assaf, so I will not discuss into this. So again, the conclusion about placing an IOL, amidst the time pressure and the stress of the situation, it's understandable that surgeons might be tempted to implant the original IOL selected, particularly if appropriate backup IOLs are not available. It is therefore important for ophthalmologists to prepare for this contingency by having a backup IOLs in the operating room and having a preoperative or intraoperative method for determining which power to use. If an appropriate backup IOL is not available, it may be prudent to defer IOL implantation to a later date rather than implant an IOL of improper size, improper power, or design. So now you have put your IOL, or you left the patient aphakic, and you have a dropped lens matter. There is a place for medical treatment. One study that was published again in the Journal of Cataract Refractive Surgery and reported that retained lens fragments can be managed conservatively with good visual results. Vitrectomy was effective only in patients with retained lens fragments not responding to topical or oral medications. And the results indicate that surgery can be successfully delayed in certain patients. But is that study really something to follow? I myself, from my perspective, I don't believe that conservative treatment has any role in such instance. Why? Because are you willing to put up with patients complaining of disturbing long-lasting floaters? Are you willing to convert a simple treatment from 1 or 2 medications to more complex topical and even systemic steroids and glaucoma medications? Are you willing to have an unsatisfied patient with poor vision for weeks or months? Are you willing to act after it is too late when retinal detachment develops or you have uncontrollable glaucoma? I think the answer is no. So when to interfere? Optimal timing of vitrectomy continues to be a debated issue in the literature without a consensus. However, one report said that there are favorable visual outcomes with vitrectomies performed within 3 days of cataract surgery. Why? Because they say intravitreal macrophages are absent when lens matter is removed within the first 3 days. Immediate or early vitrectomy theoretically should reduce the severity of uveitis and the incidence of CME and glaucoma. So non-controlled retrospective studies of vitrectomy performed on the day of cataract surgery have shown varying visual results. Better, in some reports, worse, similar, compared with surgery performed at 1 to 4 weeks after the incident happens. Some authors speculate that the lack of data supporting early vitrectomy may be attributable to selection bias. Why? Because these eyes may be judged to have a higher risk of post-surgical complications. They undergo early vitrectomy, which may mask a significant treatment effect. So immediate post-plan vitrectomy can usually be performed without technical difficulty and prevents the patient from requiring a second surgery. And as Dr. Asaf said, you can just, the patient is finished and he goes home without knowing that he had a complication. But two issues may limit the same day vitrectomy. First, the availability of a simultaneous vitrectomy by a retinal consultant to remove dislocated lens fragments. You have a retinal consultant working in the room beside you. If you don't have this, this will be a difficulty. The second thing, some vitreoretinal surgeons are reluctant to perform immediate surgery on patients with whom they have no professional relationship. So this is something that is maybe a problem. But I think most of the vitreous surgeons are so flexible and friendly to his cataract colleagues. And they are doing it for free, by the way. Kado يعني, جدعانة. Delaying vitrectomy until later the same day or the following day may be complicated by suboptimal visualization because of corneal edema. In these cases, it's prudent to wait for corneal clearing before proceeding with fragment removal after a few days. How? You can use 20 gauge, fragmentomy can be used in hard cases, but I will show some cases we can use the vitreous cutter using the two-crush technique. And Tarek Hassan was the first to report that he can even do it with 25 gauge. Of course, it can take longer time than 20 gauge with fragmentation. I myself did 14 cases in the past 3 years, and I only use fragmentomy just in 2 cases, even with whole lens dot. So the procedure included 3-port sutureless vitrectomy, removal of residual cortex under the IOL, complete vitrectomy with removal of posterior hyaloid if possible, removal of all dislocated cortical and nuclear matter, and 360 degrees indentation to exclude any retinal breaks. So this is an example of a patient that was referred the second day after cataract surgery. He was nicely managed by his cataract surgeon. There was a dropped nuclear fragments and cortical matter. He put a 3-piece IOL in the sulcus. He did a good anterior vitrectomy, but he did not suture the corneal incision. First thing I did is to put 10-0 suture to ensure the integrity and the formation of the AC. I don't want a lost AC. I don't want the IOL to be mobile. So we can go sutureless. We put the infusion can. The most important step is that you make sure that, because those eyes sometimes are hypotenuse, you have to make sure that the infusion canal is in the vitreous. The worst scenario, you put a suprachoroidal infusion and you turn the nightmare into a nightmare that is twice, a dropped lens matter with a suprachoroidal infusion. So you have to make sure that the infusion canal is inside the vitreous cavity, and if there is any tissue, you have to clean it first before opening the infusion, making sure that you see the shining metal part of the infusion canal is inside the vitreous cavity. And then you put your other 2 sclerotomies. Again, this surgery might seem easy, but I think it requires experience, an experienced vitreous surgeon, because you don't want any retinal breaks, you don't want suprachoroidal infusions, you don't want retinal detachment. So you actually want to have a clean, nice attached retina with a healthy macula. So the first thing is to so it's working first behind the IOL to clean the lens matter that is in the anterior vitreous, and then you do your vitrectomy. You might find some nuclear or epinuclear fragments. You can easily remove them with a vitreous cutter. This was not really a tough case because most of the dropped lens material was quite soft. And then you can chase every single piece almost until you remove completely all the lens matter that is in the vitreous cavity. Again, you check all the periphery. At the end, you have a nice clean retina. And at the end, you remove your cannulas. And you have a nice, almost untouched eye. So there is no much of an invasion to the eye after the vitrectomy. Again, this case is a case that was done on the same day. Okay, so the cataract surgeon was working in the next room to me, and then he said that I have a dropped nuclear fragment. Again, you can go this was just 1 hour after the cataract surgery. Once he just divided the nucleus, it dropped at the back of the eye. Again, he managed the case professionally. He did an anterior vitrectomy and put a sulcus 3-piece IOL. All my job is to go at the back without violating the vitreous from his part. You do a proper vitrectomy, a 3-port vitrectomy. Again, you can completely crush the nuclear fragments. Sometimes I put a drop of perfluorocarbon on the macula just to protect the macula, but it's really not necessary. But if you are more meticulous, you can do that. And then you can remove it at the end of the surgery once you are done with the patient that is potentially 20/20 vision. Again, you remove your cannulas and you are done. In some cases, in this case, this was a whole lens that was dropped at the back of the eye. Okay, it was probably great for nuclear cataract. So I tried to remove it with a vitreous cutter. I tried to crush it between the light pipe and the vitreous cutter. I couldn't really divide it, so it would take hours to remove it by the vitreous cutter. So there's no point to do this. So what you can do is just you use a fragmentome. Okay, I tried once and twice. So again, you remove one of the cannulas. You don't have to really open the conjunctiva, do a keratomy. You can just use a 20-gauge MVR to enlarge your entry site. Okay, and then you can use the Phaco fragmentome. Of course, you don't use the Phaco fragmentome until you do a proper vitrectomy. You don't want to engage the vitreous with the Phaco fragmentome because this can induce retinal breaks. And you aspirate and you work in the mid-vitreous away from the retina until you can completely divide again and completely remove the whole nucleus. And again, I put a perfluorocarbon. At the end, you can just take one suture of 7/0 vicryl and remove your cannulas. You can put additional sutures if you want, and these are absorbable. But again, the eye is really untouched and it's very quiet post-operatively. So compared with vitrectomy 20-gauge technique, 23 transconjunctival vitrectomy eliminates the need for conjunctival keratomy, reduce surgically induced sclerotic trauma, corneal astigmatism, and mean operative times, reduce post-operative patient discomfort, intraocular inflammation, and thereby allow for faster post-operative anatomical and visual recovery. So retina surgeons using sutureless 23-gauge vitrectomy for such unfortunate incident can save their fellow cataract surgeons any patient dissatisfaction, and they can fulfill their promise to the patients of having fast sutureless surgery with minimal post-operative discomfort with excellent visual results. This is just one of the articles. I think it shows the recommendation for backup IOL, and I think it should be in your reference to know what to put in such cases. Thank you very much.
معتذر بس احنا